Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Osama Nizar Kashlan from Ohio. Dr. Kashlan is a neurosurgeon at the Cleveland Clinic in Ohio, United States. He also serves as flight surgeon in the Air National Guard. Dr. Kashlan received his medical degree from the Emory University and completed his neurosurgery residency at the University of Michigan at Ann Arbor. He then completed a complex minimally invasive spine fellowship at the Emory University, followed by a fellowship in endoscopic spine surgery at the University of Washington. He is a member of the Endoscopic Spine Research Group and is the inaugural secretary of the International Spinal Endoscopy Research Foundation. If you noticed, Dr. Kashlan has delivered a lecture on a channel that's already reached a huge audience. And today is my great honor to bring back Dr. Osama Nizar Kashlan for this wonderful live program. Over to you, Dr. Kashlan.
Thank you so much, Professor, for this invite, and thank you to Orthopedic Principles for giving me this opportunity to talk about something I'm very passionate about, which is minimally invasive spine surgery. Today specifically, I wanted to talk about minimally invasive posterior cervical fusion. So these are my disclosures here. I have a teaching contract with Arthrex and with Joymax to teach endoscopy. But I first wanted to talk about what is minimally invasive spine surgery. It's not incision size. It's an approach to the spine that respects tissue planes, minimizes collateral damage, lowers postoperative pain, shortens recovery, and decreases complications and provides for less need for future interventions. So really, in the lumbar spine, this has been great. I mean, I think we have expanded minimally invasive options in the lumbar spine drastically. Now we have anterior approaches, OLIF, so anterolateral approaches. You have lateral approaches, and those approaches respect tissue planes. You're not going through any muscle. They really fulfill all the requirements of minimally invasive surgery. And even for posterior approaches, now we have great, minimally invasive ability in the lumbar spine. So whenever we have to go posterior in the lumbar spine, meaning we can't do the muscle sparing, we have the ability to spread the muscle rather than detach it and really use the smallest working channel diameter possible, which endoscopy gives us the ability to do in the lumbar spine, and the lowest number of working channels possible, meaning biportal versus uniportal. Whenever you're able to do uniportal to do the same job as a biportal, that's less working channels there. So in the lumbar spine is great. We have multiple approaches that respect the tissue planes, whether they're anterior or lateral, and we have great options of muscle spreading, whether it's with a tube, whether it's with an endoscope, whether it's biportal. So we have great approaches in the lumbar spine. And the question is, it's important also to make sure that these approaches also give us the ability to give us the same outcome or better than our traditional open approaches. And the question in the cervical spine is what has hampered the development of minimally invasive approaches for fusion in the cervical spine, unlike the lumbar spine? And it's multiple things. The first is that we have a phenomenal option already that fulfills all the requirements of minimally invasive spine surgery, and it's the anterior approach. You're really able to do so much from a small incision, very little disruption of our normal tissue, and able to do, for example, a 3-level ACDF through a tiny incision and perform the job needed: decompression, realignment, great fixation. So we really have a great option in the cervical spine already, which is the anterior approach. These patients usually go home the same day or the next day. So there's really, I think this is the biggest reason why we've lagged behind in the cervical spine. The second reason is for lateral approaches, you have the vertebral artery. So that also is a huge reason why different minimally invasive approaches have been hampered in the cervical spine. And the last thing is the musculature in the posterior neck is composed of numerous layers, all with very thick fascial planes. So really any type of minimally invasive approach that's muscle splitting has to go through numerous layers of muscle with super thick fascia, unlike there is in the lumbar spine. But I wanted today to go through our attempts to perform posterior cervical fusions minimally invasively. And our first option that we have here, so there are 3 attempts at making posterior cervical fusions less invasive. And I want to go through those 3 techniques. I'm going to focus more on the last one because that's the one that I have the most experience with, not because it's better or worse, but that's just the one that I'm most experienced with. But I did want to talk about all 3 because I do think it's important for spine surgeons to know all 3 and have them in their armamentarium for the right patient. So the first one here is described by this paper by Dr. Cork and the rest of the group in Carolina, and it's minimally invasive cervical pedicle screw placement. So we know that cervical pedicle screws are stronger than lateral mass screws. We know that they're great, but they're higher risk because you have to have the right anatomy. The vertebral artery is in the way, but with navigation, you're really able to put cervical pedicle screws in a very minimally invasive fashion. So you can see here in their paper, these are figures from their paper. So A shows the reference frame attached to a spinous process in the lower cervical spine pointed inferiorly. B shows the use of the navigation probes to find the perfect approach for our pedicle screw. C shows how you make a skin incision for all 3 or for all 4 screws like you're looking at here, but you're making small fascial incisions for each one, and you put your pedicle screws in with tulip heads, and you're able to pass the rod like you see in our second figure in A. You're able to pass the rod just like you do for in the lumbar spine, and you're able to get great fixation, 3-column fixation in the cervical spine through very minimal disruption in the fascia. You have 2, again, larger incisions on the side in the skin, but there's tiny little holes through the fascia, so it disrupts the musculature a lot less. So this is an option that we could do for posterior cervical fusion. In terms of arthrodesis, you can either put a tube down to put bone graft and arthrodesis the joints, or you could use navigated burrs to arthrodesis the joints. So this is a great option for the right patient. However, in my experience from doing this, which is very little, I feel like the patients have some atrophy of the muscle. As much as we try to minimize the disruption through the fascia, you end up disrupting more than you think. So there is some atrophy that I've seen in my experience that makes this not the right choice for every patient. And obviously, you have to have the right anatomy. The vertebral artery and the foramen transversarium have to be amenable to these types of fixation. So this is the first option that you have to make things less invasive. But you see, there's no disruption of the nuchal ligament. There's not these awful, midline incisions where you have the scarring going into the wound. And we've all had those patients where the posterior cervical laminectomy fusion patients just have awful neck pain and have awful looking scar that indents into the wound. So this minimizes that a lot. The second option that we have are minimally invasive transfacet screws. So these have been used for many, many years. So this is an example here of using a facet screw through C3, 4, 4, 5, and 5, 6, and 6, 7. So there are multiple techniques of how these transfacet screws are placed. There's a Del Canto technique, the Klecamp technique, Miyanji, and Takayasu, and those have different projections in terms of the laterality of where you're projecting the screw, the starting point. They're very small differences. And there's a cadaveric study that shows that these can be done minimally invasive rather than open. In that paper, there's a cadaveric study. It showed that the chances of infringement into the foramen transversarium was higher with the minimally invasive technique than with the open technique. But that paper, they used radiographs. They used X-ray. With current navigation and the improvement in the navigation systems that we have, these techniques can be done much safer through a minimally invasive approach. And there's a renewed effort and a renewed interest from whether it's companies or surgeons in enhancing hardware for this technique to make it better. Because I think if this technique, we have better fixation, we have good navigation, it could be something that could really give us a great minimally invasive option. And at the end of the day, without having a rod there, you're not having to pass that rod through all that musculature and disrupting everything. You're really able to do this through tiny little incisions. And this definitely would fulfill the requirements of a minimally invasive posterior cervical fusion. So this is the second one. So we talked about the minimally invasive pedicle screw placement. Now we talked about the minimally invasive transfacet screw placement. Our last option here, and this is the one that I have most experience with, is minimally invasive facet cage placement. There's a great video from the company that I'd like to show. It's about a minute, so I will kind of come out of the screen here a little bit so we can look at that. And that's just a great way of explaining how this works. And I'm sure many of you have already seen this, but this device here, I use it a lot, honestly, and I think it's a great device that fulfills a lot of requirements for a minimally invasive fusion. So this is obviously a bigger incision than what you need for this. Usually you just need a tiny centimeter incision. And this all comes in the same package. So you get an introducer into the facet joint, and you arthrodese the outside of the joint. Then you put the introducer for your cage in there. And you see it gives you a little bit of indirect decompression. You arthrodese the inside of the joint with this instrument here. And then you put your cage in there, and you can fill that cage with graft or BMP. So there's a cage right there. And then the new device they have, you can put two screws, one screw into the inferior facet, and then the other screw into the superior facet. And then you can backfill with graft afterwards, like you'll see in this figure right here. So you can backfill with graft in there. And then over time, you have all what's needed for a great arthrodesis. You have a very minimal distance, which is the intrafacet distance. You have a bunch of bone graft in there. You have a great titanium cage. And yeah, so I think this, until now, in my hands, this is probably the best way of performing a minimally invasive cervical fusion, at least in my hands. So let me go back into the presentation. So let me do this here, exits, and then go back into it. Okay, so we watched this video right now, and now I want to go through my experience with it. So this takes a little bit of a learning curve, not from the surgical, how to do the surgery. The operation is honestly very, very straightforward. It's really just to be comfortable that this is going to work. So the first cases that I did with this device to do a minimally invasive posterior facet or posterior cervical fusion is for these patients. So we've all seen these patients that have had ACDFs done where there's a non-union. So you can see clearly this is the 2 or 3 years after having a 2-level ACDF in a 40-year-old patient who is still having neck pain, where she has non-union in the 2 levels that were operated on. So this is someone who traditionally you would do a regular posterior cervical fusion with lateral mass and a rod construct. Very disruptive to the neck musculature. And if you have someone coming to you with neck pain, I feel like that you're giving them more neck pain. Maybe you're taking care of the problem, but you're giving them more neck pain. So for this type of patient, I think the posterior minimally invasive facet fusion is a great option. This is how I started. So this patient here, I accessed the joints. So this is the introducer, the arthrodesis of the outside of the joint, and then this is the cage. So did that for all 4 joints, as you could see here. And on a CT performed just 3 months later, we're starting to see some bony fusion around the cage. And at a year, I had a CT that showed that these are completely fused. So, and the patient's pain got better. So in this situation, we were able to do this operation through 2 tiny incisions rather than a big midline incision for a fusion. And the patient did very well. So this is where I was like, okay, you know what? Maybe there is something to this device. And then we started doing more and more complicated stuff. So the second use that I had for this was really improving fixation when the traditional fixation was not ideal. Again, I just wanted to gain more um, confidence in this implant. So the next thing that we did is, so this, for example, was for a Jefferson fracture here on the left, a patient that failed conservative measures, had a chronic fracture there, and performed a C1-2 fusion, but really just did not have the best fixation there. So rather than going cranially and caudally to include more levels, you can really put this cage into the facet joint at C1-2 and added a lot of fixation there. And this patient ended up proceeding to heal, which was great. And then the second patient here on the right side is someone who had a occiput to C3 fusion performed many years ago for some type of trauma. And as you can see here, developed adjacent segment degeneration right below that construct at C3-4. So for this patient, she was young. She was in her 40s. I really did not want to fuse that many more levels. So offered her a front back to just treat the level of the problem rather than extending this construct more inferiorly. And as you can see here, posteriorly, just to really augment my fixation and augment my construct, added these minimally invasive facet cages from the back, which again added fixation. So now I said, you know what? I think this is a good option. Obviously, in these two patients, it wasn't done through a minimally invasive incision. But again, like I talked about earlier, minimally invasive spine surgery is not an incision size, it's an approach. I think in both these patients, that construct allowed me to feel more confident without extending the fusion and fusing more levels. And therefore, that to me is minimally invasive. That's at least in terms of the approach. So then lastly, this is when you say, okay, I think this device works. I think minimally invasive posterior cervical fusion is a great option for these patients. So this is a patient here who came into the ER with rapidly progressive myelopathy, has a disc herniation and ligamentous hypertrophy at C3-4 with kyphosis, causing significant stenosis and T2 signal in the spinal cord. So as you can see here, offered him a front back. So traditionally, I would do, ACDF and then flip the patient over, lateral mass, rod construct. But for this patient, I said, you know what? Let's try these minimally invasive options. So did an ACDF from the front, and then flip the patient over, and then put in these minimally invasive facet cages through two tiny incisions. And this patient ended up doing very well. Ended up healing and recovering much of his symptoms, so or alleviating much of his symptoms. So this is when I said, okay, this really this technology can take off, and we could do more complicated stuff with it. So this patient here came in to the ER with, again, rapidly progressive myelopathy, has stenosis at 3 levels with kyphosis. So for this patient here, offered him a 3-level ACDF, which you could see here, with multiple unattached cage plate screw constructs. And I got a post-op MRI that showed that still had a little bit of stenosis posteriorly at the upper level. Not the worst, definitely better than pre-op, but the patient, I just wanted to give him the best decompression so that he could heal the best over the course of the year. And offered him then to back up his construct and decompress his spinal cord, and decided to decompress his spinal cord with the endoscope. So you can see whenever you start thinking minimally invasive, you can add all the techniques in your armamentarium and put them together. So this patient here did an endoscopic laminectomy. So this picture here on the left side shows the superior lamina. So we came in from the left side to do, this is detaching the ligamentum flavum from the superior lamina. The second picture shows us detaching the ligamentum flavum. And in here, you could see slowly, so on the left side here, seeing the ligamentum flavum in the middle with epidural space above and below. And then you start seeing resecting that ligamentum flavum with the kerrison that you could see here. This is decompressing the contralateral side, and you can see a beautiful decompression here in the last picture of the spinal cord, and postoperatively got an MRI, which demonstrated a great decompression of the spinal cord there. These are our facet cages that we placed at the same time to augment this construct. And these are the incisions. So this patient had an ACDF incision, which is standard for all of us spine surgeons. And then you have these three tiny little incisions in the back, this top one here for the decompression, and the bottom two for those facet cage placement. So really gave this patient the most minimally invasive option possible, looking at the principles of minimally invasive spine surgery that we talked about at the beginning of this presentation. So then the last thing, this is kind of like the final boss, is using this as a standalone. So this patient here is a patient in the upper 80s presenting with myelopathy, and really was not interested in having an open option. Also had significant kyphosis with spondylolisthesis at the levels of the stenosis at C3-4 and C4-5, and it was mobile. So on dynamic films showed some movement on flexion extension, and really was significantly affected by his myelopathy. So he's an older gentleman, but super, super active, and really wanted to get back to his life. So for this patient, usually, I would have offered him either a corpectomy from the front, a C4, which in an upper 80s age group, high risk of dysphagia, as we all know, or would be someone that you would do a laminoplasty or a posterior cervical laminectomy infusion. Laminoplasty, some people would say maybe not a good idea because of the kyphosis and the dynamic instability. So I wouldn't offer him like a laminoplasty, but I know others would. But for this patient, traditionally it would be either a C4 corpectomy or a cervical laminectomy infusion in my hands. But what we ended up doing is a cervical endoscopic laminectomy at C3-4 and C4-5, and a posterior minimally invasive facet cage placement. So this is the post-op MRI. You see the cord is completely decompressed at the two levels at C3-4 and C4-5. You can look at the nuchal ligament. It looks like it is untouched because you make such tiny holes through the nuchal ligament and through the musculature that you don't have this atrophy that you get with our traditional open procedures. And you could see here the minimally invasive facet cages placed at the C3-4 and C4-5 levels. So this over here, like I said, it's like the final boss of doing minimally invasive posterior cervical fusions. And it's, again, something that you build up to in terms of confidence with these procedures. So in terms of the take-home points, in the cervical spine, the anterior approach is such an incredible approach that fulfills all the requirements for minimally invasive spine surgery that any posterior approach has such a high threshold to meet before it becomes something that's useful for surgeons. So we talked about the three approaches that we have now for minimally invasive fusion in the posterior cervical spine, which is the pedicle screws, which we talked about first, the transfacet screws, which we talked about, and I think is having a renewed interest as our equipment is getting better and navigation is getting better in the cervical spine. And then the third option, which we talked about the most, not because of anything other than the fact that it is the one that I had the most experience with, and I know it works. So we talked about these three options, and then lastly talked about how you can blend these with the anterior approach and endoscopy to give patients the same final outcome as doing open approaches, but with a lot less morbidity, smaller incisions, quicker recovery time, and decreased time in the hospital. So I appreciate you all inviting me for this talk, and I hope that everybody got something out of this. And I really appreciate you, Dr. Pitesh, for making this opportunity happen.
Thank you, Dr. Kashlan. Thank you for this wonderful presentation. Dr. Kashlan, can you stop sharing?
Yes.
Thank you, Dr. Kashlan. Brilliant talk and great work at Cleveland.
Thank you. Appreciate it.
Let's take some questions, Dr. Kashlan. Now, for this particular procedure, the MIS posterior fusion, the best results are with navigation alone, right?
For the first two options, yes. For the third option, you can use navigation, meaning for the facet cages, there is a way that you can navigate them. And I've done that before, but honestly, with the fluoroscopy, you're able to gain with biplane fluoroscopy or just moving the X-ray machine from AP to lateral multiple times. I usually don't do that with navigation anymore because I'm so comfortable doing it with X-rays.
Okay. And is there any technical risk that I mean, it's a very precision surgery, right? That risk for going into the foramen transversarium.
So in terms of the pedicle screws, you always want to look before at the anatomy to make sure that the patient is amenable. The anatomy is amenable. The foramen transversarium is off to the side. For pedicle screws, the person who taught me how to do this, so Dr. Feng Zhang at University of Washington, when I was doing my fellowship there, he said that even if you go through a third of the foramen transversarium, that's still usually okay. So most patients, I think, are amenable to have the pedicle screws. So I think for that procedure, obviously, you have to look at the vert anatomy. For the transfacet screws, that is the one that has, just looking at the literature, the highest chance of impingement or infringement of the foramen transversarium, and that's why I think navigation is going to make that a lot better. For the facet screws, the way that the implant is made with that, so you saw that holder. That holder has a stop. So as long as when you're going into the joint, um, you're not over malleting that thing in there. There's a stop there, and it stops you before you go even close to the foramen. So um, the answer to the question is yes for the first two options. The last option, unless you really mallet, like, and you go past that stop, you should not have any vertebral artery injuries unless
And
there's
you're
ever.
very comfortable with fluoroscopy.
Yes, so that's last procedure. Fluoroscopy is what most people use, but again, you can use navigation. You could attach one of the navigation probes to the introducer. So that's very, very doable, and maybe it helps with the learning curve of doing that procedure. But honestly, with any surgeon, especially surgeons who are putting in pedicle screws with fluoroscopy or freehanding, they're very comfortable with the anatomy, and they would be able to do this very, very easily.
And most of the cases that you've shown are in conjunction with a revision scenario or in combining with an anterior construct, right? The only one case where you said that it's a standalone was that elderly gentleman who didn't want to go anteriorly. So is that the only indication for MIS posterior infusion? I mean, posterior fusion, usually in conjunction or in such cases, elderly man who doesn't want a major surgery anteriorly?
Uh, so a great question. I think it's a comfort level of the surgeon. I think initially you're like, these little cages are not going to do anything. Um, but I do think the first two options, so the facet or the pedicle screws, you could definitely do them standalone, 100%. The facet screws, the transfacet screws, those you could do standalone. And in the presentation, the example from the literature shows that. The facet screws, I am just finally getting to a point of feeling comfortable with doing that. I think there's going to be a lot more evidence needed and a lot more, I think, patients that I make sure that they're doing okay infusing in a year before I say that the facet screws doing them standalone or the facet cages doing them standalone is a good idea. But I think the first two options, definitely okay to do standalone.
And Dr. Kashlan, one last question. Now, we see a lot of young people, right, who have this severe cervical radiculopathy. There's a disc prolapse and early onset nerve root deficit, no myelopathy. What is your approach? How do you go about it? Do you go anteriorly, posterior, endoscopy?
Yeah, no, I mean, I think for me, if it's, I'm always in my mind looking at, it's like an algorithm. Can I do endoscopic posterior foraminotomy, microdiscectomy? If it's a unilateral radiculopathy with a disc herniation off to the side. If the answer is yes, that's always the number one option. If not, then usually, so for me, I'm always trying to, if I can't do a cervical foraminotomy, whether it's a tube or endoscope, I always try to go anterior. Like if anything that there's equipoise, anterior versus posterior, I always go anterior. And always try to do motion sparing. So try to do an arthroplasty over a fusion if the patient is amenable to it. So I think a soft disc, unilateral radiculopathy, if I think that the disc is lateral enough that I could get it with the endoscope posteriorly, that would be number one option. If that doesn't work, then, or if it's not an option, then it would be an anterior arthroplasty prior to doing any type of fusion operation.
If it's a single level, just do a posterior foraminotomy and take the disc out, right? And if it is multiple level, go anterior and do a arthroplasty. Does it make sense?
That makes sense, but honestly, even multi-level, if the discs, if the discs or the foraminal stenosis are all on one side, I've done up to 4-level foraminotomies before. So I think that
Or
is an
posterior,
option posteriorly. Yeah, I think that is an
endoscopic.
option.
Endoscopic?
Endoscopic, either endoscopic or tubular. I've done it both. Um, and I think that's a great option, honestly. If it's unilateral symptoms, even if it's 3 or 4 levels, I really think it works. Obviously, it's very rare to do that many levels, but I think multi-level, as long as the symptoms are unilateral and the whatever the problem is, whether it's a disc herniation or the hypertrophy is on one side, then usually posterior foraminotomy is my first go-to. And also the caveat that there's not significant kyphosis. As long as it's a straight spine or a lordotic spine, I think that's a great option for these patients.
Thank you, Dr. Kashlan. I think that's all the questions that we have for the session. Thank you for this wonderful talk and really look forward for more cutting edge work from your side.
I really appreciate that. Thank you so much.